So this panel, Kevin asked me to sit in because I'm very passionate about it, and we're at a point where we keep saying healthcare is unaffordable, and then
Healthcare's unaffordable.
thank you, I got one vote, and then rates just went up for a bunch of people, and they cut the payments, the insurance payments for people that don't have enough money for health insurance. So I'd like to have go down the line and have each of you just say, who's here, this is who I am, this is who I represent, my organization does this, and kind of keep it as, pretty brief. Don't go into the whole presentation because we want to, I'm a taskmaster, I guess. So we'll be talking about tax policy, HR 2927. Oh, I'm sorry, that's the next one. The 340B. You guys are now the tax panel. No. 340B, PBMs, drug costs, healthcare deserts, which we got into a little bit with your talk, and healthcare as a public utility. Healthcare as a public utility is we're doing a primer right now, which is thinking of everybody needs electricity, so there's commissions that manage how much they can charge and how much they can make in profit, and we think the same should be said of public utility, of healthcare. And I think I'd like it, whether you're for it or not, I'd like to hear from you guys. So let's just start off with introducing yourself, what organization you're with. There.
Sure. So my name is Ray Serrano. I guess I'm just Dr. Ray on the forum here, but I just have pretty informal, so I always go by Ray. My background is actually in health economics. My doctorate's in health economics. I work with I used to work at CMS, Center for Medicare and Medicaid Services, for the longest time, and then kind of had the activist bug in me, and I just felt like I wanted to kind of help out and be a part of the solution. So the League of United Latin American Citizens, I would say, is a Latino cousin of the NAACP. The NAACP was formed in 1909. We were formed in 1929. They have chapters. We have councils, 435 of them throughout the country. Largest and oldest Latino civil rights organization. And I think within that, the focus on healthcare is as a civil and human right, of the idea that it's a basic form of human dignity. The way of restoring dignity is having access to that healthcare. I grew up in a migrant farm worker family, so for me it's like a single parent household. Mom worked 2 jobs, 16-hour days, so it's very near and dear for me. So I joke at my office, my formal title is National Director of Research and Policy, but my informal title is the residential nerd. And then the other part of the story, they say I'm a very lonely nerd. So I have a whole, a nerd team at LULAC over here down the street here. And so we do a lot of regulatory comment letters and everything to try to defend the right of access to care for folks.
Thank you.
Good afternoon, everyone. I'm Dr. Brenda Leith, and like many of you, I wear a number of hats. Today, I'm representing my small business that's based here in the District of Columbia, but part of how my journey has taken me in terms of career path, I have done a lot of cross-sector work. I have worked on the Hill in terms of working through a congressional commission that was focused on the prevention of infant mortality. I've worked in corporate research. I currently am in the public health arena, working at the Public Health Institute. And I also do a lot of consultant work relating to community-based organizations, one of which is based in Macon County, Alabama. And we're looking at rural health initiatives. And then another is a quality improvement organization that's based in Ohio. So I hope that my thoughts are organized when I have to respond to Brady's questions because of these different hats. But it's a testament to me saying to you that I feel like there's so much intersectionality across the different domains that I work in that I feel like I can make a contribution. And what I want to also say is that early in my career, without having the actual credentials in biomedical ethics, that was something that was a passion of mine. So that is what I earned my doctorate in. Thank you.
Once upon a time. No, I'm just kidding. I'm just kidding. Yes, so speaking of wearing a couple of hats, you heard from me the other day about historical preservation, but my professional background is as a business developer and as a business consultant. I started out in public accounting and went into consulting and development. I then began doing healthcare development, designing hospitals and building operations for spas, hospitals, wellness centers. I've done extensive amount of healthcare work here in D.C., Montgomery County, and Prince George's County. Some of you may be familiar with the Minimally Invasive Vascular Center in Laurel. We also had one in Reisterstown. I built those operations and just kind of got grandfathered into this whole healthcare space. But now I'm very passionate about it because being in that field on the other side of the table and kind of seeing some of the things that Greg and Megan were talking about, how they were constructed, was appalling to me. And so even though now the spaces are built and I still do some consulting, I still have to advocate because I just can't walk away from what I saw.
Thank you. And I'm clearly the dumbest guy on the panel because unlike all of my fellow panelists, I'm not a doctor. But hopefully I can hang with all of them. Of course, worked for a PBM, as we all just talked about.
Okay, excellent. Let's keep it with you, Greg. The 340B hospital drug pricing program and pharmacy benefit managers are two of FSIC's main issues because we could talk, have a whole day conference or 3 or 4 days about the problems with our medical system, but we see these are two that really affect the communities that we support. And so if you could comment on just a little bit on that, you know, whatever knowledge that you want to share. And then is there a policy, if there's like one thing that we could look at policy-wise, trust me, I'm not going to volunteer you for anything. What would that be? And then if we can go down the line, because we have people from different walks of life here that are highly educated and highly knowledgeable, and I'd like to hear from you.
Yeah. So thanks, Brady. Somehow, if you wanted to pick a pharmacy topic that's more complex than PBM, you go 340B. So thanks, Brady. Yeah. Let me do that in 2 minutes. But to take a step back, do you guys know what the 340B program is when anybody says that? Okay. So at the end of the day, back in the 90s, the government said, hey, drugs are starting to get expensive and they're starting to get unaffordable. So they started this program called the 340B program. And so it's a program that's only available to certain not-for-profit hospitals. And it gives those certain not-for-profit hospitals in rural, underserved areas the ability to buy drugs at a significant discount than they would otherwise be available on the market. And there's these crazy calculations that go into how they come up with the drugs. But just for perspective, my two favorite, or we've talked for years about insulin being too expensive. 340B covered entities, as they're called, which are the hospitals that can buy insulin for a penny, 1 cent. Have you guys ever heard of Humira? Yeah. That's 12 cents. Otherwise, it's about $10,000 a month. So it is a significant discount for these health systems to buy these drugs. And the original intent of the 340B program when it was created was to allow better medication access to low-income people because these hospitals are typically in lower income or underserved areas, right? So if you're a hospital, you know, that's usually a large academic medical institution in a really high-income neighborhood, you would never qualify for the 340B program. So there are specific qualifications for these hospitals. But over the last 10 years, as per anything when money's involved, the entire program, in my opinion, has been bastardized. Hospitals are now using this to drive profits back to their own systems. Very little of this money that was supposed to help lower income people afford their drugs helps anybody afford their drugs. So we now have used the 340B program just so certain systems can do bad things, in our opinion. Now, there's still a lot of rural systems that rely on this 340B program to stay in business. But I do think if we were going to look at it, let's just at least go back to the intent of the program and start putting some rules around the intent so that we can actually help people afford their drugs and not create a new profit center for systems. Would be the easiest way I would put it.
Okay.
And that's building into the legislation that we're going to be introducing this year. So.
One of the things that was most appalling to me in learning healthcare is that most of us restrict our healthcare solutions to what the insurance companies will pay for. And when you start talking about 340B, when you start talking about reimbursements, sometimes there are services that we need that either are too expensive or that maybe the insurance company doesn't pay for that we don't even know about. So when I started to look at the number of people that were losing their lives because if they just had access to a particular drug or a particular treatment, and then on the other side of it, a lot of the doctors then become box checkers because they don't want to get in trouble. And so they don't want to say to you, you should try this or you should try that or let's go for this option. Or they say, well, you know, we were in vascular surgery, so they say, I'm going to try to go in and clear your arteries twice, but if it doesn't work, insurance company's not going to pay. So these are some of the additional things that are happening to us as a result of this really messed up healthcare system. So one of the things that we also tried to do was to try to make things accessible to people to the extent that we can that they maybe normally wouldn't be have access to.
Well, that's some good work. Yeah.
So my perspective is going to be a little bit different because, first of all, one of the organizations that I'm representing here today, as I mentioned, is in Macon County, Alabama. They don't even have a hospital, so they don't have the program. Wow. So we have to start at ground zero for them in terms of we need to get a hospital in place.
What's the closest hospital?
There's a couple of counties over, I can't remember the.
30 miles, 40 miles?
I don't actually know that, so please don't.
No, it's okay.
I
was
can't.
curious.
It is a distance, but I don't know what the distance is off the top of my head. And, you know, it's looking at how can we build infrastructure there so that there is access to a hospital facility. That's where we need to begin in that setting.
So I think for me, I've always been a kind of a contrarian on certain things. And when I first time I heard about 340B, it was an event hosted by Pharma, and they were talking about it, and they made safety net hospitals seem like these bad, horrible places. But I thought to myself, you know, the Latino population, if you lined up all the people in the U.S. who are uninsured, 40% of those people are Latinos. Because there's 1 in 6 Latinos, and there's 1 in 10 African Americans. So where's the usual source of care? It's the safety net hospitals. So those big, bad hospitals are the ones that are abusing this. And I'm like, well, they get a lot of uncompensated care. Because a lot of folks, they can't turn them away to the emergency room. I guess now they can, I guess, in Texas. And for whatever reason, they're checking immigration, accusing us for not being citizens. But so then I thought, okay, yeah, you know, I think it's big bad pharma just trying to take more profits. Then I read the Cassidy report. Good nerd that I am. It's 197 pages. Read through it the whole weekend. And my sister's an OBGYN. She's a gynecology obstetrician. She was at the University of Washington for medical school. And part of her training was at the Yakima Clinic. It was a farm worker clinic. One of the stories she told me when she was there was a patient, she was about 6 months pregnant, and she didn't have a ride. Well, she came to see her at SAR at maybe like 1 o'clock. This is in October, so it gets kind of cold. By the time my sister ended her shift around 8 or 9, that patient was still sitting outside. 6 months pregnant. She had no ride home. Her sister didn't get out of work. She had her husband, I don't know, he was still working. She had no ride home. When I read in the Cassidy report, I saw the Yakima Farm Worker Clinic and saw how much money they got from this. That 340B program I thought to myself, this is horrible. And the way I've always broken it down is like in 1996, when they formed this program, it was a drug discount program. Think of like coupons. The government was going to give coupons to poor folks to use towards their drugs. But instead of giving the coupons to the folks, they gave it to the clinics. And they said, and some of the cashier says, well, you know what? I'm going to put the coupons in the back room. Or I'm going to pocket the coupons for myself. And if it was Caremark, I'm going to charge you a fee to use that coupon. And they ate up all the savings. The savings, you saw the patients paying the same without without any discount or even higher in those 340B hospitals. And if they didn't pay, they were the first ones to run to the collections. They were the first ones to report. They have higher collections for 340B affiliated hospitals than the non-340B hospitals. And that just told me they really are sticking it to us. And I there's policy and there's pissed off Ray. That day pissed off Ray came out. So
Okay. No, this is great. It's just such a thing where I just have to take a deep breath, because we used to have a thing called fraud in this country. And I know that the legal definition of fraud doesn't really count toward hardly anything anymore unless one of us does it. And the fact that they're taking drugs at such a low cost and turning that into profit, and it's supposed to be for nonprofit hospitals, but the top, like 80% of the program goes to like 10 hospitals, and they're the big for-profit ones. They're like, well, how do they do it? The intent of the law is gone, and we're not policing that kind of stuff anymore. And that's why we're trying to change the rules. We don't want to get rid of it, because there are hospitals that really need it, especially like in the gay and lesbian or gay community, HIV treatments. You know, there's a system for that, and they rely on these drugs because they can be very expensive. So one of the I'm in a coalition with Dr. Ray here, and that's one thing we talk about is we can't get rid of the program. We just need to reform it. So the next question is, when it comes to, you know, health deserts, the thing that you said when you gave your talk was just stunning to me, that they've cut out thousands of pharmacies, and we know which communities they're out of. We call it pharmacy deserts. We call it healthcare deserts. Is there a way, whether it's using the post office, or if there's an idea that we could build into what we're doing and trying to pursue here? I would love to hear your opinion on that. And I guess just go back down the line again on this.
sure, I think like when you think of like a health desert, think of like a food desert, like the availability of the clinic within, whether it's like how close it is, how whether you can afford it. I think I know I was going to say this for mental health. Like I know for our councils in South Texas, one of the things they pushed for is to in the local libraries in South Texas to have these little rooms so people can do their telehealth visits there, especially for mental health, because people didn't have cars to go to to go out to therapy sessions 3 times a week or 2 times a week or whatever it was, but they could jump on their phone. And if they brought their kids to the library, they could have some peace. They could take the kids to the library, and they could run to one of the small rooms. That's something that we advocated for in our organization. I think technology can bridge that gap sometimes, but it's hard, because I think the people who are most affected by these health deserts are the folks that are least likely to come to a meeting, least likely to testify. Their voices are there. They often tell each other these stories, but they never quite get back. And the ones that are attuned to the policy are the ones who are kind of creating the health desert, right? The Caremarks, pick out the PBMs. But these are the ones that are, they have so much money, they have lobbyists, they have state directors, they have, you know, even regional directors, district directors to lobby and to push for certain things. Or they fund other organizations to do it for them. And their voices get amplified tenfold. But the ones who are really suffering the consequences are the ones that are not doing that. So I always say we, the majority, we need to like just speak out, find a way to get your voice out there. Sometimes even a letter, or talking to somebody who's an advocate who can weave your story into a letter just with a first name. You know, Andrea from Prince George's County reported this. Those stories matter, because I think when people start seeing a face, a story, that really does matter. There's power in that.
Thank you. I agree that there is power in hearing testimonials, and one of the things that I would like to say is that in Macon County, hearing the voices of local citizens has been very critical to understanding what they perceive as priority areas. And it also has helped to elevate their voice and their empowerment to feel like their voices matter and count. We've had a number of roundtable discussions and conversations in the county that engage folks, and actually that process has been institutionalized. We're going to be launching soon a series of summits locally that engage different counties that are going to be collaborating on different healthcare priority areas. The other thing that I wanted to say is that in terms of deserts, there are lots of deserts and healthcare deserts in the counties that I'm talking about, because this is in the Alabama Black Belt counties. And so what I want to say about that is it's interesting, if I just take one example of maternal and child health. It's only been in the recent couple of years that the midwife policies have been restored, where they are no longer considered illegal, because at one point they were for many, many years. And so that may seem like a minor thing, but it's a major thing, because it's been a lot of years that they weren't in place or allowed to practice. And so rebuilding that is part of what is going to happen in Macon County. I'm excited to be a part of that because I feel like I can contribute. I'm excited also that the local residents are going to be helpful in informing the directions that we're going to go in, and that they're going to feel empowered to do so.
So healthcare deserts, like so much of these solutions, is multifactorial. So to me, I've been thinking about this for a while. To address it, we have to address the community, the government, and then there has to be business. So on a community level, the summits, the think tanks, expressing the need. Some of these states are what they call certificate of need states. So in order to build, you have to show a need. Of course, you would say, well, there ain't nothing there, you know, there's a need. But they're going to require you to make that presentation. Then the government, we have to have influence there because they have to approve us going in and building these hospitals. A lot of times these places are shut down, and you'd be surprised that the government, the local municipality, may deny you building a hospital or doing certain procedures. And then you have to bring in investors, and since a lot of the hospitals are run by venture capitalists, people who are investors, they don't want to go to rural areas because they're not going to get the volume. And then we have to make sure once those hospitals are built that they have specialists. So it's one thing to just go there and have somebody look at you, but you want somebody who's going to do something about whatever is wrong with you. Not to say that a traditional internal medicine doctor cannot do that, but if you need surgery, you want there to be surgeons. It's just like in a lot of the Indian reservations, they give incentives to new grads to go and work there. You've heard of that program probably, because they need those services in that area. So when we're building in these healthcare deserts that are primarily in these black rural areas, we have to think about a multifactorial approach, because it's going to take more than a notion to get them to build in a hospital that in an area that may or may not be profitable.
Greg, you spoke a little bit on this earlier, but do you mind if I switch gears just a little bit?
Thank you. Those were all great answers, so I don't want to have to go after those. So yeah, let's change the topic.
I'm looking out for you, man. I told you, I'll protect you. Healthcare as a public utility. We worked with the research department at Affirmed RX, and we co-wrote a paper called Healthcare as a Public Utility. It has a much fancier name than that, but we're really going to push this as an idea, and we may not get this exact idea through, but the idea is we've got to do something dramatic to change, and this isn't really that dramatic, but there's going to be a lot of powerful forces against us. Can you tell people, in brief, what we're trying to do with the public utility? Like when you brought it up, it was like, hey, public utility, everybody needs electricity, so we have a public utility, and there are differences. If you could address that.
Yeah, thanks, Brady. So, again, as we continue to think like the system's broken, as we talked about earlier, right? It's run by for-profit companies who have a responsibility just to make more profit. So how do we think about a different system is always been kind of our framing question. And as we continue to think about it, hey, if you look, as a society, we believe everybody should have access to power. So we have power utilities. Telecommunications, we have telecommunications. We have water, right? Sewage. So don't we at the same time as a society also believe that everybody should have access to healthcare? And when we look at utilities, like one part of it kind of breaks for what we're saying, because some people would argue utilities exist because of the high infrastructure costs that go into building these things. So that's why you allow utility to exist. And maybe you don't have the high infrastructure, like we don't have to build power lines across an entire community in order to do healthcare. But at the same time, there's a couple of concepts of the utility piece that I think start to matter. One is the utility is run by a board of people who use the utility. It's not run by a board of people who have a fiduciary responsibility to maximize shareholder value. And as a healthcare company, shouldn't I, as the CEO of a PBM, be responsible to the people that we're serving? So why would I care about having a board of people who use my company tell me how I can best do things to maximize their value and provide better outcomes to them? Like, why do we not have that as healthcare companies? And then additionally, from a profit standpoint, I think there's fair profits and then there's unfair profits. And again, we've moved way past unfair profits in healthcare. Like, that ship sailed 10 years ago and it continues to get further away. But, at the end of the day, like Southern Company is one of the largest utilities in the country. They're huge. They're publicly traded. They're worth a couple $100 billion. So we can have utilities that are publicly traded. So if we care about capitalism, which a segment of the people we're talking to care about capitalism, right? And the forces behind it. Cool. Well, we can point to utilities that are successful financially, and they're still run by the people who use the utility. So how do we try to start thinking about healthcare in that way, as opposed to, again, the definition of insanity, just allowing these companies to be run for profiteering purposes? So that was our basic framing and why we ended up where we did.
Wendy, I had a little bit different question for you, but I do want to hear from Dr. Leith and Dr. Serrano. But Wendy, I'll go with you first. So part of the problem with access to healthcare and the reason we need healthcare as a public utility is because there's the facilities owned by non-white or non-huge organizations are being put out of business. I know that that's a whole panel in of itself, but because we've done the work on it with your help, can you give a little summary of that and why that's important? Because you're going to see that in the legislation that we introduced this year.
I think we all have figured out that the healthcare industry is probably one of the most gangster industries. I mean, as a developer and as a consultant, I've worked with a lot of companies and I've never seen anything like it. The massive amount of profits, the things that they do to stay in business. If you are a non-white male and you try to open a healthcare facility, get ready for the ride. Because, and I if you don't mind, I don't mind sharing this. When we opened in Prince George's County in Laurel, we got death threats. My business partner, who's a surgeon, another group of white surgeons met with him and gave him a list of zip codes. Said, we better not catch you operating on people outside of these zip codes. We had people that worked on our front desk was like, oh, I'm out of here. These people are calling. So it is very difficult. We had to, when we were building the building, we had to take all of our mechanical stuff and shift them inside of the building, which added on about another $300,000 because people kept cutting our lines. And so we ended up with armed security at the front desk. Patients felt very safe, but we knew why they were there. It's a very, very gangster industry. And so we have to be ready for this when we start addressing food deserts. I can't tell you how many times my tires were flattened At the time, Mayor Marion Barry, may he rest in peace, he was in the Wilson building, and his office actually called me, and he said, I heard about what's happening. And so he started trying to make phone calls for us to try to say, hey, look out for these people. They're trying to do something good for the community. But it's very challenging. And the wolves that come out, you got to be prepared for it. So this is not a lightweight fight. And you got to be here for the smoke. You just have to. And if you're not, then this is just not a place you want to be, because the healthcare, what do you call them? Gangsters, I guess. They don't play. And you got to be willing to confront. You got to be willing to challenge. And they have people and places in government, in community, in other hospitals. I mean, we fought Prince George's County Hospital tooth and nail. And you just got to be ready for it. But this is what it's going to take to make change. Then you have some systems, like we built a radiology center on Reisterstown Road in Baltimore, and they were a little bit better, but at first they just wouldn't even talk to us. So there's a lot of time that's wasted trying to get meetings. So you just got to be ready for it. And if we're going to say, okay, healthcare is going to be a utility, we got to say, all right, we're going to be in for the fight. There's infrastructure charges. There's the service charges that we have to be prepared for. We got to make sure we got specialists. You can't do it without specialists. And a lot of times people think of doctors and healthcare, and I know they're thinking only about the primary care physicians, but you got to think deeper than that, because most of the time, most of our issues in at-risk communities is because we don't have access to specialists.
It's tough for everybody, but particularly, and the results we know are better if somebody can go to a clinic or a specialist that looks like them.
Yeah.
The cultural understanding of that. So thank you for your efforts.
Sure.
Dr. Leith, if
We
you
got a
could.
question behind you, Brady.
Oh, okay, yeah, let's take a few questions.
Good afternoon, it's Earl Pete. I'm a finance guy, I'm not a health guy. I trade out to business finance. You want me to use to speak with you? I thought I could talk like I was in church. Good afternoon. So I'm in finance. My question is, I've recently been asked by a friend to get involved in the HUD 242 and 233 program that guarantees the construction of healthcare facilities, particularly in rural areas. And I was wondering if you all had a perspective on that in terms of making more healthcare available in rural areas using this HUD program, which I'm just learning is available. And I'm not in the healthcare space, but I'm in the finance space. Thank you.
I can answer that a little bit in that in most of our cases, no bank, no HUD program, no SBA would touch us until we were about 60% boots in. Those programs do exist. I've never seen them work on a startup, and I've never seen them work or even be activated when the developers have not put in a significant amount of money on their own. So you just have to be ready to spend, because it's going to cost, especially if it's a certificate of need state, it's going to cost a lot just getting your architecture and everything together before you can even go and present it to them. So you just have to be ready for that cost.
Let's go to Dr. Leith. I would like to know what you think. Oh, do we have any other questions? I really want this to be interactive.
Just a question. Does all of this apply to senior health care centers? I know a lot of black folks are getting into that business. Are they having to go through this kind of situation as well?
So you're talking about like rehabs? You mean like rehab centers, senior health centers, and things like that?
Yeah, or just senior living and
Senior-
that kind
okay.
of thing where you have to have the health components
Yeah, so
available?
that's a little bit different
Okay.
because in some of those cases, and I don't know what it's like now with all the funding cuts. I know in D.C., I helped do a few. I partnered with the D.C. Office on Aging, and they had assistance and funding available through the wellness centers. Some of those wellness centers are inside of senior housing facilities. And and then we would bring in screenings where specialists could come in. So in some cases, it's a little bit different if the healthcare infrastructure is already in place. So in DC, we kind of just relied on the existing healthcare infrastructure and got them to bring services to the seniors. Does that make sense? In a rural area where the infrastructure is not there, that's a horse of a different color.
Any other questions at this moment? Yes, Rick?
Just a quick comment about, we've talked about rural hospitals, medical facilities. I live in Atlanta, in the Martin Luther King district, right next to Atlanta Medical Center, one of the largest, second largest hospital in Georgia, which, as I was leaving to come here, they had just finished bulldozing 2 city blocks of the hospital because they closed. Too many poor people. And now the medical center has went 50 miles out to all wealthy communities and is building facilities. So it's very sad, even in a big city like Atlanta, when you lose 500 beds
Yes.
in a hospital, it's a bad thing, right?
Yes, it's a huge challenge because in many of the urban areas, in a lot of the urban centers, there are not adequate hospitals unless it's a trauma center, somebody gets shot or something. But in a case like that, those same women who have babies still got to drive 50 miles. They're almost in the same situation as somebody in a rural hospital. What they generally do, what the venture capitalists oftentimes do, is they'll close a center like that and they'll come in and bring in an urgent care or some kind of small medical that has limited services. You already know that in those communities, those are usually the sickest of the sickest. And that's just not going to be enough for them. And it's not going to be, but it more than likely became unprofitable, especially if the state cut a deal with one of the gangsters in a big box hospital, and then the state didn't give money to that safety net hospital, if you will.
Do you want to talk on that and then?
I'll get to you.
So one of the things about the Affordable Care Act when they came in is it's kind of a wonky term, but it's like DSH funds, disproportionate share hospital funds. The idea is that like you have a lot of uncompensated care going to safety net hospitals, and with uncompensated care, basically, folks who go to the emergency room, don't have insurance, have no way to pay for it, and they write it off. And the hospital used to get money from the federal government to say, you're a disproportionately shared hospital. You have a lot of uninsured folks coming to your hospital. As they started cutting that back, because the idea for the Affordable Care Act is that more people would get insurance. And so then you wouldn't need to have disproportionate share hospital because there would be more people with insurance. Part of that meant that the bigger hospitals, the Emory Healthcare. I used to live in. I did my PhD at Emory. The Emory Healthcares, Piedmont hospitals, they would eat up the smaller, more rural hospitals or urban hospitals. They started eating them up. 340B is another one. They started eating up. It started leading to more hospital consolidation, and so basically, big hospitals, gangster style, basically ate up the smaller ones. And then on the scope of practice. Those laws in Georgia, they did not. The American Medical Association was very keen on keeping scope of practice only for doctors. They didn't care that 36 counties in southern Georgia didn't have a pediatrician. they didn't care about that because, God forbid, they needed high quality. What? Nothing? There was no pediatrician there, so they would have to drive 50 miles to get a pediatrician because they wouldn't. They couldn't have a nurse practitioner. God forbid. A PA, God forbid, no. They'd rather accept that they would have nothing in lieu of having a high-quality doctor 50 miles away.
Dr. Lee, can you speak on that?
Sure. What I should have said earlier was that while the area doesn't have a hospital, it did have 4, and they all closed. And so, you know, it's interesting that one of those hospitals actually was a VA hospital. And there is capacity in terms of the physical structures that exist there to rebuild and renovate. But it also takes money to do that. So when you mention partnerships, that is part of the approach that's being used to try to have some type of degree of economic recovery in that area. In terms of healthcare as a public utility, yes, I agree. I think that that's a good concept. I like philosophically where that could take us. I think that it leads, in my mind, it leads to universal access to care as a basic and essential type of right as opposed to a privilege. And I think, you know, we have a long way to go in order for us to make that shift, because right now, today, the mindset is not there for healthcare as a right. But I think that that is where we should land.
Could I make- sorry, could I make- quick- So, a couple of things on the. I read the white paper. Great. I think one of the challenges for policy is quite often we lack imagination. Right? We don't. It requires first the imagination of like, what does it look like to really reform something, and then we'll debate of how we get there. But quite often we're just stuck at like, what does it look like? And I think what I liked about the paper is the forced imagination of we could look at healthcare as a utility, and then we can argue that. I also like when you mentioned that they're gangsters. I'm like, whoever controls the command of the language, because we did have this like when the Affordable Care Act was passed, there was the IPAB, the Independent Patient Advisory Board. I'm originally from Idaho. Another crazy Idahoan is there. We don't really claim her. Sarah Palin. And if you remember when Sarah Palin ran, that was her thing. IPAB, the Independent Patient Advisory Board, was going to be the death panels. They're going to kill grandma. You have unelected bureaucrats. They're going to kill grandma. And that was the narrative that they used. The language they controlled, she controlled the language to say these unelected bureaucrats are going to kill your grandma because they don't value human life. Again, and it sold. And they killed IPAB. It's still there, but they reduced it down to just an advisory board. It couldn't offer things. And then they also said, well, if they pass this, it's going to lead to rationing. I'm like, what are you talking about rationing? You go to the clinic if you don't have money to pay for it. That's a form of rationing too, like as if that was like something new. Like, but they used their language so strategically, and they controlled that. So that for me was. But the other thing, so then just to be contrarian, on the utility part, and I'll be very honest and very frank here, like working for a civil rights organization, working for a Latino organization, being in a space of even dealing with minority organizations, this city has a way of having very big actors, the Verizons, the tech, the Metas, that they give money. What they can't do. They give money to other organizations to do it for them. I call it the caramelization of greed. It's good old-fashioned white greed with a brown sugar coating on top. And it's usually somebody, I'll say it very frankly, because the California Public Utilities Board has, it's a charter I'm telling you probably more than I probably should, but Charter Communications is eating up another of these little smaller companies. And they can't, the Verizon folks can't actually write the letters to them. So they get these small groups to write these letters and comment letters. We had to do that, and I had to upload the letter. And I remember that one of the comments somebody wrote back, it looks like these letters have been have been written by lobbyists. I'm like, because they were, they were written by lobbyists. And no one funds civil rights. No one funds this space. No one cares about immigrant rights. We need to get money somehow. And sometimes it means dancing with the devil to get money from them in order to do the other work that we try to do. And it's sad. It is super sad that we have to do this, but I'm just being very honest. If it's the utilities, like it is, those bad actors don't go away. They find new ways to try to circumvent the system. So just be careful.
Okay, let's go down to Greg, and then we'll each have we got about 5 minutes left. If we could each get a final comment on something that you think is important for all these community leaders to hear regarding our conversation, or if there's something we haven't got to that you think is important.
Yeah, I guess I would just maybe double down on my comments, and I think, Ray, you hit it good. I say it a little different, completely unpopular, but words matter. And I still think one of the best framings ever was out of that National Rifle Association on, guns don't kill people, people kill people. I mean, they wrote that for decades, and that was a great statement that spoke to a lot of people, whether you like it or not. And that's what we always try to say. Like, what's that soundbite for healthcare that we can try to get the right action behind? And the best that we've come up with, and I'm not saying we've landed here that it's right, but again, everybody's bitched about healthcare for decades, and the companies that run it continue to make more profit, and us that use it continue to have worse outcomes and pay more. And again, it's the definition of insanity. So, the only way we're going to get change is to force change. And if we continue to just allow it to happen to us, they're going to continue to make money, and we're going to continue to pay more and get sicker. And I don't like that outcome. So these conversations are great with you people, so that we could all try to figure out how to get that answer right, because I don't have it by myself, right? But maybe we can all do it together.
I am remiss. Mr. Flores has a question.
Thank you, Brady. I've been part of this panel and other panels, and we talk about deserts. You talk about healthcare deserts. You've got banking deserts. You've got food deserts. You've got affordable housing deserts. Is anyone looking at a holistic approach to this? Because they're all affecting the same communities.
I just love it when somebody helps
That's a
or
question.
volunteers.
You got a question over there?
Somebody
That sound like a
volunteers to
Keegan
help us
question.
solve a really complex problem. But okay. So does anybody want to comment?
You got a
Before?
question over there?
No, I was just
Well, he had his question. So
Oh, I thought he was commenting.
responding in the affirmative to his question
Yeah.
in terms of an approach to all of these deserts.
okay.
A holistic approach?
I don't even know how to
Wow.
how to phrase that. That's something that we look at everything spherically in terms of if you don't have an education, you can't get work. If you don't have work, you can't get health care. If you don't have health care, you're not going to be able to get work. If you don't have any of that, are your kid what are your kids going to have? So it's everything touches everything like a relational database, and we'll have to yeah.
So a long, long time ago, I used to work with the UN Development Program, and one of the things that we did at the UN. So I worked in Zambia. I went kind of international before I went domestic, but I worked in Zambia, and I worked at the UN Development Program. And one of the things that they do, the UN Development Program, is the Human Development Report. So when we hear the rankings of kind of the beauty pageant of say like Norway's the most developed country and Burkina Faso is the least developed, it's a bunch of indicators that they do, and they have certain indicators that say okay. Broadband access, like hospital access, like maternal mortality, all of these things go into the soup, and that gives you the score. And that's what says Norway's doing really well, Burkina Faso is doing really bad. We don't have that for the U.S., but I think we need that because that's what, if you had a score to basically kind of the misery index, and you had an index that say these counties are miserable in so many different ways, I think it would draw. Like Americans like rankings, right? That we like this Alabama's at the bottom and Massachusetts at the top and whatever education or stuff, but they like the idea of knowing that to just put it out there, and it's important to have that. But I don't think we have done it at a more granular level to really combine things. So I think I would challenge that.
Okay.
Over here?
On that point, yes, that's what the whole socially responsible investment industry has been working on for the past 30 years. We developed the fully adjusted return methodology, which is a way of calculating social return that tells you how to allocate resources where they will have the maximum social return. That's what we've been working on for about 30 years. So you're absolutely right. There is a need, those metrics are there. It's a question of who knows about them and getting the word out. So that's it.
Thank you, sir. Okay, we got time for one more question, and then I do want to give. Yeah.
Just very quickly, I'm glad you raised that because part of our effort is not in the metrics, but more in the engagement of different stakeholders and community leaders. So we do have a multi-sectoral response that we're looking for, and that is part of the approach for empowering local decision-making.
And did you have a final comment about, we're all working together here and I just, now I can't barely talk because I'm thinking about all the things I want to do to start connecting these task forces more.
Does anybody else have one more comment before we go over to the next panel?
I was just going to say, I know it seemed a little gloom and doom when it came to healthcare. I can feel everybody's energy, but let me just say this. Don't restrict your healthcare treatment to what your insurance company will pay for. There are always other options. There are other solutions. You have to be your own advocate. Do not just sit there like a little chirpy bird and wait for them to feed you. There are oftentimes more alternatives, and you can go above and beyond. Remember, their goal is to give you the bare minimum. They don't want to hook you up. So if they say they're paying for something up to a certain level, there are oftentimes other options. Sometimes they cost money, sometimes they don't, but be open to that possibility.
Yes, Ray.
So what got me started in public health for me was like the HIV, and that's why I went to Zambia and worked in Thailand on the same issue. What I was so fascinated by is like when the epidemic first started, is that folks ACT UP, if you know the organization, it was folks who were directly impacted by the disease that came out and became really vocal advocates for treatment. They changed so much in that space of access to drugs, access to healthcare, Ryan White, whatever the cause was, they changed it up. I think that that approach of using like folks who are directly impacted by the burden of disease, whether it's obesity, diabetes, HIV, asthma, you name it, to speak out and use that as leverage to say, I'm directly affected by this. My whole family has diabetes. Let me just tell you, when you put that fast food restaurant in this area, this is what it'll do. I think having that voice, because that's what shuts up. Those lobbyists could be out there, but they're out distantly. It's those politicians listen to people who could vote for them, and if they hear people locally complaining about it, they're going to say, "Well, I don't care what these guys are telling me in D.C. I care about these local folks. If I live in Nebraska, I care what the Nebraskans do." So I encourage you, make the voices heard. Use social media. Find ways. I get my interns to get published in local commentaries. I'm like, get your name out there. Get your name out there. Start becoming a scholar. Change the conversation. That's what we have to do.
Okay, thank you. Can we have a round of applause? This is we're going to take a 10-minute break while we bring up the next panel, but thank you all for your questions.